Afternoon. There we go. You know, it's amazing. The reason that we had to change the venue was because so many people wanted to come, which I think is an extraordinary testament to what's happening in this community and what's happening in this moment and how important this work is. So let us begin by saying thank you. My name is Jasmine Beach Ferrara. I am so honored to be one of your county commissioners. I want to recognize our commission vice chair, Terry Wells, our county manager, Avril Pinder, our friends from the city of Asheville, our friends from Buncombe County Sheriff's Department, and an extraordinary group of community partners represented here in this room, as well as staff who are leading Buncombe County's initiatives in response to the opioid crisis. So everyone comes into this room with a story about who you are, why you do what you do, and why these issues matter to you. And I want to just take a moment to pause and recognize that some of those stories that we carry are stories of loss and heartache, and we carry with us the memories and the spirits of folks that we have lost. And some of those stories that we carry are stories of hope, stories of lives saved, stories of people reconnecting with those who love them, stories of people rebuilding their lives. My own story includes both of those with folks that I know, and I'm guessing that's true for many folks here as well. This is a really important moment in our community's response to the opioid crisis, the crisis of addiction, and the many related issues from youth mental health to housing, to how we respond to the crisis of growing numbers of folks who are unsheltered. The list of related issues goes on, but this moment in particular is so critical because we are embarking on a new phase of our work fueled by opioid settlement funding that will enable us to scale programs that have been launched as nimble, innovative pilots, have shown great efficacy and are now ready for the next phase of work. Funding that will enable us to launch new initiatives in response to the ever-changing landscape of needs at the community level, and will enable us to continue being what we have been in Buncombe County, which is a pace setter, not just at the state level, but at the national level in terms of how communities can come together and respond. I will close by just saying this. Since I've had the honor of serving as one of your commissioners since 2016, I have regularly met members of our community fresh in grief who are asking what can be done to save more people's lives. And one thing that is so abundantly clear is that when it comes to addiction, there are no boundaries. County lines don't matter. Race doesn't matter. Income doesn't matter. Age doesn't matter. Your religious beliefs doesn't matter. Your sexual orientation, your gender identity. It affects all of us in one way or another. That's part of the heartbreak of it, but it is also part of what gives me such hope, because it means that every single kind of person in our community has been touched by this issue and thus becomes active around this issue. And there is nothing more powerful than what happens when people from all different backgrounds and walks of lives come together with a common purpose, a common understanding, a shared experience, and a common vision of what's possible. Our work is to save lives. Our work is to help people rebuild their lives. Our work is to do all of that with love and care and compassion, and to do it in a way that is bold and innovative. And I know that that's exactly what we'll do as we move forward in Buncombe County. So with that, I'm so delighted to introduce Victoria, who is just doing extraordinary work helping lead and coalesce the county's efforts, and will kick off the rest of today's program. Thank you.
Thank you, Commissioner Beach Ferrara, and thank you everyone for coming here today. We appreciate it. I'm going to touch on some of the boring stuff, and we'll get to some more interesting content, but just a little bit of the background on what brought us here today. You will, as Commissioner Beach Ferrara spoke about, and we were fortunate that our Attorney General, Josh Stein, along with other state attorney generals, were able to negotiate a settlement with manufacturers, distributors, and that is where we are set to receive at least $16 million throughout the next 17 years through 2038. There is currently in the works an additional wave of settlement funds that we hope to hear the final word and really understand that schedule of dollars that will be coming, that will continue to allow us to enhance the programs that we have and to continue to fill in those gaps that we've identified. And so the purpose of these funds are to be supporting services and programs for those with opioid use disorder or any co-occurring substance use disorder or mental health conditions. And so when knowing that we're getting a large pocket of dollars, we understand that there's work to be done. And so we had gathered a steering committee of individuals, which you'll see some various logos and names, because there were so many people that stepped up in whatever way that they were able to. Really defining that vision. For those that have that one pager, we have included our vision, some of that detailed information that's in the report. So instead of reading the entire report, you can see that one pager and really get some of those highlights. Getting over 1,100 surveys within our community, a majority of those with lived experience, and those that identified as having loved ones that have experienced the impacts of substance use. We really identified some key indicators. How will we know if we are making a difference on that population level? And we really broke down some of those key indicators, and we'll continue to monitor those in the next 3 years to see, are we making a difference? And we explored the root causes of substance use. And with that, that allowed us to identify some of our strategies, which we'll go into a little bit more, and recommendations. But I just first want to thank all of the individuals and groups that have worked tirelessly to be a beacon of light to those needing light, long before there were any funds dedicated to their work. There are so many in our community that stand in the gap, that advocate for the needs of those being left behind, that give of themselves to give someone else a chance and a second chance, and maybe even a third chance. So many lives have been saved by just one person deciding they were not going to wait for direction or guidance, but acting on what they knew was right. Perhaps what they needed, something of themselves during a time that their light was not shining bright. And I want to thank all of our community partners for their participation in this planning process in any way they were able to. If it was 1 session, 10 sessions, if it was asking just one question that made us stop and say, let's look at that. What more do we need to do? It was a daunting process at times, but we have partners that continue to show up, ask those questions, share knowledge and experiences, and that is what made this guiding document possible. The work is not finished, but I believe we have guideposts to help direct where we focus as a community around these funds first, but also just our efforts all around. The lessons we have learned, we can build upon those as we revisit as a community what we need to heal and thrive in the coming years. And so we've learned that meeting people where they are in their most vulnerable state and building relationships has been working. Getting people to the right places and supporting them along the way has been working. Sharing life-saving knowledge and resources with a harm reduction lens has been working. However, we also found that there are significant gaps in these effective outreach efforts. People in our community struggle to access resources for safety and well-being between programs, to find support getting from one point of recovery to the next resource, and to receive culturally competent and reflective services, particularly among our BIPOC community members and those for whom English is not a first language. At the same time, we are still recovering from the mental health impacts of COVID-19, the increasing demand on our social service and medical infrastructures, and the workforce challenges that this has amplified. We have families and individuals scraping to get by. Yet this strategic planning process also demonstrated that we are recovery resource rich community with a robust network of providers and services already working to understand and create change around those challenges. We see a clear opportunity to focus on collaboration and coordination, to increase our understanding of the data we have available, with the goal of enhancing our outreach, communication, and education community-wide. We recognize the importance of uplifting our young people, listening to their wisdom, and prioritizing that we equip them with the tools they tell us they need. We have heard a call to enhance access to treatment, housing, and employment resources by coordinating our efforts. And finally, we understand this moment as an opportunity to promote community and connection as a platform for recovery. And so part of the work our steering committee has done with our goals and strategies was to really look at a dual approach. We need to save lives today. We continue to see our numbers rise, but at the same time, we need to apply that same sense of urgency to longer term planning and to address systemic root causes. And so really looking at how do we share this data? How do we understand what's happening in our community so we can be responsive and nimble? How do we increase that access to treatment, what people would like, that they need? And how do we understand how that's effective and who is being left out? And along with that, we need to help provide those bridges to care, right? They need to know where to go, someone that's able to check in with them, to motivate, to show them how to do it. And we also want to make sure that we are teaching and sharing the life-saving medication of naloxone, sharing those risks and those resources that are available, and that we're making sure we're reaching our entire community. Early intervention is obviously an important piece, meeting the needs of our youth, teaching them the ways that they are able to help each other and connect to those resources, but centering it on our youth's voice. And then employment. As someone is in that journey of recovery, there is need to be some support and guidance and access to educational opportunities to expand their ability to continue their path of recovery. And then we know housing is an important thing in our community. There are not enough, but we did learn that we have a lot of recovery houses. How do we help those that are wanting to start recovery houses understand what best practices are, being able to recognize what programs are providing those outcomes that individuals would like to see? And then how do we expand those opportunities to meet all the needs of our community? And so right now, based on our guidance from commissioners and based on the feedback, what we know today is that we'll be switching to, I'm saying switch to the slide, but I said that is we will be focusing on continuing our collaboration and coordination between departments within the county and with our community to really continue to actualize these recommendations. We're also looking at contracting with someone as a medical professional. When we use the word epidemiology, it's kind of like a data specialist, someone who has that language, that understanding of how do programs work together? How do we use this data? What are those trends that are happening? How can we get ahead of situations such as xylazine? We know that that's coming into our community. We see that happening, and we're going to continue to see that increase. And how are we knowing what populations we're seeing this in? Are we sharing with them the tools and resources that are needed? And then also we are looking at a 911 diversion. So to really explore how can we divert people to alternative locations than the hospital, making sure that they are able to get those resources. So there's lots of opportunity as we really evaluate some of our calls within 911, what are those alternatives and what's available in our community to divert people to those resources. And this in turn would open up our EMS and advanced life-saving to respond to those potential fatal overdoses. So someone does have another day to have an opportunity. And then we'll be focusing on recovery support services. There are some services that we're continuing. So I just want to highlight in bold are what we are expanding and what we are adding at this moment. So we'll continue to make sure people are getting linked to services, that we have those opportunities and understanding what's available, as well as that naloxone distribution. We will be adding an additional community paramedicine team to be that bridge. Right now, our community paramedics are working regularly to connect people to those resources. And there are more opportunities to connect those folks and to give them that support as maybe they are leaving the emergency department, as they are leaving the detention center. We have several individuals that at times could benefit from this service, but they have not been in the detention center long enough to really get evaluated and connected. Can we help capture those people quickly? We know that there is greater risk after leaving the detention center for a fatal overdose. So are we able to capture them, provide them that resource, and connect them to our providers in our community? We also have funds to address some of those social determinants of health, transportation. We've got medical appointments, dental appointments, or whatever those things that's for someone's well-being. We'll also be adding work around making sure that we are crafting our message with our communities, getting that feedback from our communities about what that message should look like, and giving those materials that are necessary to get those messages out. And so with that, our next phase will be actually reaching out to probably several of you all to understand what are your capacity, what's available, where could we potentially grow, understanding those pathways of care and making sure that we are filling in those gaps as best as possible. Understanding that that coordination is going to be important on how we respond to crises and to prevent people from falling through the gaps. And as well as understanding that data. I know a lot of you are collecting information, and how are we using that as a community to inform our response and to coordinate together as we look at other opportunities to supplement our opioid settlement funds. As you all know, the opioid settlements can't do it all. And so how do we all work together to really meet the needs of our community? So I hope this has given you a sense of what we are looking at doing in these next year and where our focus will be. And what we would like to do at this point is to invite our panelists. We have Zakia Bell-Rogers with Buncombe County Cape, who will be moderating that. And so I will allow her to take over, and panelists, please come forward. I appreciate you all joining us and sharing, because again, this was the boring piece. What does it sound like in person? What does it feel like in action? What are we seeing and hearing? So thank you all.
Good afternoon, and thank you so much for joining us today. And I think Victoria said, I am Zakia Bell-Rogers, and I am going to allow this wonderful panel to introduce themselves, because it is better to hear what someone is doing from them with the passion that comes behind it. So we're going to start with you, Samantha.
Okay, is this Mike? Okay, I'm Samantha Bradley. I work at Sunrise Community for Recovery and Wellness. I work as the RCO coordinator. And what that looks like is Sunrise is the recovery center organization from Charlotte over. And I don't know if any of y'all have been over to our drop-in center, but our goal is to have drop-in centers in every county from Charlotte over. So that is my job, is to help those kind of come to fruition. I also have a program that we started in Cherokee. I am an enrolled member of Eastern Band of Cherokee Indians. And so I love Buncombe and all the work they're doing, but I felt like it needed to be duplicated in the rural area. And so we built a program called Shikwo Don and Na, which means they are living again. And it's basically a reentry program on the reservation. And I'm a peer supporter. Thanks.
Thank you.
This is where everybody needs to pay attention. I have an accent, so please. My name is Sergio Fernandez. I work for Aspire Youth and Family. We work in 26 counties. And let me see, can you hear me now? Is that better? I work for Aspire Youth and Family. We focus on helping clients between the ages 12 and 17. We help them with interpersonal skills. One of the good things about our program, we also get them ready, especially those that are a little bit older in age, that might don't want to go to college. We prepare them with job skills, for example, cooking. We teach them how to cook with chefs from the area. We also teach them how to create music and computers, how to create things that are too new for me, like podcast and music for commercials. We have a great success. About 70% of our clients see success in our programs. I like to think about our programs as a prevention for what we're about to talk. So that's me a little bit. And the accent is from Argentina, if you were wondering. Thank you.
Hey, everybody. My name is Justin Hall. I work with Buncombe County's community paramedic program. My current role is as a peer coordinator with that team. My kind of background is I am a person in recovery. I've been now for about 7 years. Been working in the field of mental health and substance use for the last 5.5. With that, I've worked with ACT teams, CST teams, so Medicaid, Medicare, state-funded programs, as well as some private insurance programs, and did some peer bridger work that way. So I've kind of seen both sides of the coin, especially now with us having a grant-funded program, which has given us a lot more flexibility with how we can work with people, which is pretty amazing. As you guys all know, that may deal with the insurance side of things. It can restrict a lot of access to care for people, which again, our whole focus since we started our community paramedic program 2 years ago was how do we create more access to care for people? How do we fill those gaps that are currently present in the system that we're trying to navigate through? Our program is specific to the opioid epidemic, so we follow up on every overdose that occurs in this county. And our community paramedics try and make contact with the individual at the scene, encourage them to work with our program. We offer up to a year of case management support. Over the last year, we've created a pretty good program of BUP in the field, or BUP on the bus, as it sometimes is called. Our paramedics are now able to induct people at the scene of an overdose with Suboxone if they're ready and they want that. We don't require it. We don't require our people to do anything. If they're still going to continue to use, and our focus is just to help get them harm reduction supplies and hopefully keep them alive long enough to want to enter recovery, that's what we'll do. So that's kind of where our focus has been over the last couple of years, and we're now moving into more of the homeless community as well, because often they're struggling with the same sort of things. And if it's not substance use, they still need that kind of outreach and connection. So that's sort of my role. Also, I'm an addiction and drug counselor and have my EMT certification as well. So trying to sort of understand all the different areas that go into why people use. There's a lot of factors. It's not just their desire to use often. So that's a little bit about me, and happy to answer any questions at some point. Thanks.
All right, can you guys hear me? I'm Erin Bowman. I'm the director of the JFK Alcohol and Drug Abuse Treatment Center. So I've been doing substance use treatment in this area for about 15 years now. And so I've seen kind of the progression in Buncombe County and how we treat folks with substance use disorder. And so we're doing a lot of things right here. The other part, the reason that I'm here today is because I also do consulting, and I'm consulting with Buncombe County around recovery housing. And so I got to talk about recovery housing with a lot of people in our community, a lot of the things that are working, some of the things that aren't. And so I can talk about that a little bit today. So I'll be kind of wearing two hats while I'm here today.
Thank you all so much. So the next hour and a half or less, we'll be traveling together for a conversation and talking to people who have both personal and professional experience with substance use in Buncombe County. This discussion will seek to cover background and helping us understand conditions that led to substance use, current state of substance use and related harm in Buncombe County, barriers to change, what helped, and the work that is happening and making an impact on our community today. Future state, what would you like to see happen in Buncombe County with substance recovery? The panelist reflection, and we will end this with audience questions for about 15 minutes left. I also want to say that I had Cassia White, who was slated to be here today, but she had an emergency. So there will be some changing in the question. But I also want to remind everyone the things that we will talk about can become heavy.
whether you're a caretaker, a family member, or a recovering person. Please take time to take care of yourself. If you need to step out, there's an exit door here. You can go around where you entered, and before you get to that desk with a nice officer, the restrooms are down there. But please take care of yourself, because we can't ask you to take care of our community if you're not caring for yourself. All right. So we're going to start, and this is open to all of our panelists. And so feel free, after I ask the question, to jump in and answer. So I know that we all hear so many myths about different ideas about substance abuse. Can you talk about how people become users of substances?
I can start. It's a deep, there's probably, I could say a lot on it, but basically for me, growing up on the reservation as a Native American, generational curses are real. And my whole family on my dad's side, really struggled with, substance use, domestic violence. And I just thought that was normal. I remember, which I think all that caused anxiety. And right now you can see, like, I'm like hot. I'm also a person on MAT, and my medication just makes me really hot. And I'll talk more about that. But yeah, growing up around it, I mean, my own brothers are the first person who experienced it with, and honestly, I just thought it was normal. I remember thinking I got into a relationship and I was like, I was like, are you not going to hit me? Like, I really thought that every relationship was abusive, and I just couldn't believe that someone wasn't going to like physically fight back with me. And that kind of like woke me up. I mean, I don't know. I still difficult for me. But so I think a lot of that caused my anxiety, which again is why when I was using, I didn't feel anxious. And, you know, again, I'm on MAT. So when I first used, it really messed up my receptors. And so I kept going back because my receptors were like craving that normalcy. And so now, yes, I have anxiety, but it's not near as bad. And I'm not using because I am on MAT, which kind of helps me feel normal. And so, yeah, I believe that generational curses has been definitely influenced my time using.
I'll add to what Sam's talking about. So I'm a trauma therapist. And so, you know, really talking about adverse childhood experiences and where people come from, it makes a difference. It makes a difference, you know, where you're born, how much money your family have, what color you are, like all of these things affect, you know, your use of substances. And so I think, you know, there's not a lot of people who use substances who had this wonderful childhood. There are probably some, but I haven't met a lot of them. But folks really, we have to think about what happened to them and how do we approach that situation? How do we always know that we're, you know, thinking about things through a trauma-informed lens, because we have no idea what someone has been through or what it took them to get there. So I think to Sam's point, you know, trauma is what I see as the biggest indicator of a substance use disorder.
I can add that just from the inside out, some people are predisposed genetically to use or have that within themselves. Also, the education. If we don't have enough education to tell us when we're growing up, this is right, this is wrong, this can kill you, this cannot kill you, also plays a big part of it. The social economics, yes, it's a huge part of that too. Also the surroundings where you are normally. You can be in a great social economic place, but your friends are not, and those friends might be in other places. It's who you with. We used to say, tell me what you eat and tell you who you are. That's what we say in Argentina. Tell me who you with, and I tell you what you're gonna be or who you are. But yes, from genetics to poor education or lack of thereof, from the social economics for the social partners that we pick to be with, it can be many ways. I mean, when she first asked the question, I smiled because it's so many ways, so many avenues that can go lead to drug use or abuse that it's hard to pinpoint one.
Yeah. And from what I've found, not only through my own story, but in the people that we've worked with, so you've got kind of what started the substance use, and then you've got what keeps them in the substance use, right? And oftentimes they're the same, but they're not always. I'm sure you guys have heard by now. If not, I think it's a great quote. The opposite of addiction is not treatment. The opposite of addiction is connection. And I think that's so huge for myself. I was one of those people that on paper, I did have that kind of perfect childhood supported life. Now I'm kind of working through some events that were traumatic that I definitely recognize as contributing to my substance use. For me, for some reason, I always felt uncomfortable in my skin, no matter where I was or what community I was in. And drugs allowed me to remove that and build connections with people that I probably wouldn't have been able to do, or just wouldn't have been able to do. So what I found, and I don't know if Mark Seiler is here or not, but he is one of our wonderful clinicians that's working with our team and has been doing tons of work in the field with the homeless population for years. One thing he mentioned to me the other day, there's someone that's in the community that has been in recovery for a number of years now, works in the community. And one of the things he said that was the pushing point for him, it was, if you look at like a scale or a balance, every time something bad would happen, something gets put on, one side of the scale. Every time somebody in the field would treat him like a human as he was out in the streets doing his thing, something would be put on the other side. And eventually enough of those positive interactions tilted that scale for him to finally recognize, I am worth this. All these things people were telling me, I can do this too. And I think that's important to remember, and that we all have to keep in mind as we're working with these populations is how are we interacting with them, reacting, responding, whatever it may be. So sometimes it's just that little bit of encouragement or even just validation that can go a long way. So I think that's important to note too.
Thank you. Those were all great answers and very informative. For our next question, we're going to lend them to Aaron and Sergio. And that question is, when asked, what will help? One of our public surveys stated, making access to treatment as easy as accessing the drugs. How do we make treatment this accessible?
Actually, just preparing for today, yesterday I went online, and if I put myself, and I said to myself, if I am a person looking for help today, well, first of all, I would probably have a hard time getting into a computer. Probably I would have a hard time having internet. But let's say I sort those out and I'm sitting in front of a computer, and let me imagine myself being a teenager. All right. And I put myself on substance abuse treatment for teenagers. There were so many that show up as I was happy. I started clicking on them, and the vocabulary to begin with was very confusing for me to be a 45-year-old man. Then there was the question about insurance. Then was the question, if you call here, you might be transferred to there, and it was hard. To be honest with you, it was really hard if I didn't know the system. Now, knowing the system, I know exactly where to go to, but not knowing the system was really hard. And the problem is, a lot of times when somebody is looking for help, they have that light bulb on for about a minute. When that light goes off, they go off on the streets, or they go and drink, or they go and they do that kind of stuff. So the accessibility, although it might be out there, it is not one click, come and pick me up. That would be wonderful. I'm right here, pick me up, you deal where I'm supposed to be, because I do not know how to look for that. We cannot assume that somebody that has been using for a long time or is just getting involved in the world, the real world for the first time, 17, 19, 16-year-old is gonna know how to get to that point. So if we're able to make that happen, oh my God, that would be amazing. Also, we have the stigma. Also, we have that is not enough information in the schools. There is no information sometimes at home. I know the statistics from before, but if a family takes a child and talk about addiction, once a month, when they're teenagers, the chances of them using for the first time go significantly down, significantly, you know what I'm trying to say, down by 80%. You talk to them once a year, if it goes down by 50% down. So it is very important to have that conversation. Now, imagine we have that conversation at home and we have that conversation at school. Oh my God, that would be amazing to be able to do that. And it doesn't have to be a class that you sit down every day. One class a month, that is 9 months of school, 9 classes. That would be amazing. Well, I don't know if I answered the question. I think I went off, but go ahead.
It's actually to Aaron, yeah.
Yeah, so I'm
Oh.
gonna adjust your question because I heard you say a few things. And one of the things about housing and being able to have all of those things in one place. So my question will change for you and it will go to, what do we know about current state of recovery houses? And what is the need for increased housing options? A need for increased housing option was one of the most frequent raised topics. So what do we know about that? Because that has been raised. And with you saying that housing is one of the most important things, along with that one click.
Yeah.
That's right.
I want to just say something to what you were talking about first, though, is accessibility, I think, is really, really important. And so we say like no wrong door, right? Like a person can walk in, have that 1 minute where they're like ready to get treatment. And then we put up barriers over and over and over again. And it's not necessarily one person that is doing that. It's just the system as a whole has all of these barriers that we have because of payment and all of those things. You know, I work with Project Cara, and you know, the one thing that we know about is if a mom is seeking treatment and she needs it, we need to get it for her right then. We don't need to have any kind of barriers. We don't need to say go to 3 different places, you know. So I think that the connection, having one person that can like pick you up and take you to that place when you need it is probably the most important thing, is that we have someone who is like, you want it right now, I'm going to walk up, I'm going to take you there, you know. So like, and there are lots of barriers around that systemically, like, right, you can't put somebody in your car, you can't do it. There are all of these reasons why it's difficult, but I think that that's important. I think the other thing about collaboration, and this goes to recovery housing as well, is that, you know, we have a lot of recovery housing in our community. So I found 71 distinct recovery houses, right? So that's Oxford House and halfway houses in our community. However, if we open 10 more right now, we probably could fill them, right? So it's today. So we've got lots of need in our community, and there's a couple reasons for that, right? There's a lot of reasons that people come to this community because we're resource rich. There are lots of Western counties that have no resources for this, so they come to our community and then they get housing here. You know, I work for ADAC. We have lots of people who are not from there that end up staying in Buncombe County after they get treatment. So with the recovery housing pieces, it's really about that connection between the recovery houses and being able to see where the gaps are and the needs. You know, I found in my research that we needed more BIPOC houses. People of color really need more support in that area. And so do we funnel or focus some of our attention on making sure that we have houses that are accessible to everyone? I also found that, you know, one of the issues is that when people get kicked out of their recovery housing because of a return to use, that often leads to homelessness for people, right? So then they go to the hospital or they go to, to a higher intensity service, or they end up homeless. And so if we had a way to catch those folks right then, and if the houses, because it is a real challenge for recovery houses, they don't want to kick people out of their houses. They want them to be stable, but they can't have them in the house with other people who are trying to stay sober at that moment. So if they had a place that they could call and say, hey, can you keep this person for a couple of weeks while they get more stable? We'll take them back. Like, I heard that pretty universally, right? And so we have to help the recovery houses to have a place to support these folks. And I think in my report called it kind of like rapid recovery housing, right?
So like a place that we could support those folks who have returned to use so that then they don't become homeless individuals in our community. So it gets really complicated, but we have a lot of foundation here for recovery housing and a lot of good things to work on. And more so than most other places in the state. So I think we have a good start and we can invest strategically and really improve our whole ecosystem, but it's really about everybody working together.
Now, purposely, I didn't mention this before. Now, imagine going through this that we just explained to you and don't speak the language.
Yes.
Now you can see how hard can it be for somebody that is not from this country. And I'm not saying from Hispanic people just because I'm Spanish. We have so many types or so many people coming from so many different countries, from so many different languages here in Nashville. So imagine you sit down in a place that you don't even speak the language. You don't even know how the system works. You don't know pretty much anything on it except how to go to work and come back. It is really difficult. And the kids from those parents who they only know how to go to work and come back are suffering. And those kids can lead to a bigger problem that there is in the community where there was none before. I just wanted to just wait and so you see how difficult it is for people that don't even speak the language.
And you just said something. You said the concern for their kids.
Yeah.
So we know that our youth population is growing in substance use. And this is for you, Sergio. Can you speak to what is currently available for children? Because we know we're youth, because we know that a lot of rules go around. You have to be a certain age and things of that nature. So can you speak on what is available for our youth and to help recover or to help them fight the risk of becoming a substance abuser?
Well, again, I was preparing for this and I went in and tried to find a free place that is going to help with substance abuse. Try to have the least barriers possible. It was impossible. There are barriers. It's not that I'm not saying please don't take it wrong. There are places out there, for example, Sunrise. So where are you? Raise your hand.
We're ready.
There. They do an amazing job. And they do a great job. I love that. We worked together in the past. But there is now many places that like bring you hungry, bring them over and we'll take care of them. There are not many places that say, we don't care if you can't pay. We don't care if you speak the language. We'll accommodate to you. The funny thing is that what we are looking for, no, let me rephrase that. What we are seeing within this context is that the person who is seeking the help needs to accommodate to those who are giving the help. And it should be all the way around. If you don't speak the language, we got you. If you don't have money, we got you. Because that's one way that we're gonna be able to save people, really. I think and again, we do amazing work with all the people here. And I know I'm preaching to the choir here. I know all of you work on this and or have worked on this, or you know about all this kind of work. But I feel sometimes that we fail those who need the help because of the barriers that we put on, the barriers of insurance, the barriers of age, gender, color, language. There are so many barriers that we are not carrying to them. They need to carry it to us, and that's a problem. The problem with youth getting into this, what is the future from our nation? I have an accent, but this is my nation too. So those kids, I'm trying to remember the statistics. In the last year, 61% of youth have increased, 61% have increased in have used drugs at least once last year. That's a lot of people. In North Carolina, first-time users, I think it went to 23,000 just for last year. So it's a lot of people. We need to take care of those that are going to take care of us in the future. We need to specialize. And I know working with substance abuse for a long time, the brain is ready. If you're able to talk to the brain the right way. The brain is not fully developed. So we need to have the ability to talk to them the way that they are going to understand. Normally we look at youth in a way that can be dismissive, but they have so much to teach us. So I'm just gonna stop there because I can talk all day about it. That's where my heart is.
Thank you so much. Thank you so much. And our next question will be for Samantha and Justin. And it will be a little altering on this, and I'll give some remarks because one of our panelists couldn't be here and they were going to speak on the BIPOC community. And so I will give a little history and data on that. Okay. So during our stakeholder feedback and survey, throughout the planning process, consistently yield things of the challenges individuals and providers face in connecting people to resources between points of contact in the system. Can you talk about what this looks like in action, where you have seen people face challenges in recovery between steps in the journey? How does affordability of treatment and insurance impact these challenges? And as someone who has had successes, what gaps did you experience?
Okay, so yeah, I can speak on this just because as I work for Sunrise, I believe that part of our mission has been to lower these barriers. And when we talk about barriers, one of the first ones I think about is paperwork, intakes. And like, I know there are some that have to be mandated, for data tracking. I know that. But one thing that we've tried to reduce is that the paperwork, especially for folks who can't read or write or speak our language. And in that case, we would do our best to find someone that can help. So I just wanted to say that on that barrier. And as far as through the process, I can remember, again, what Aaron is saying about housing. So I live in Cullowhee. I'm from Cherokee, and that's kind of where I say I laid in the ditches, basically where I did all the things, right? And there was only like one system. So you go through it a couple of times and like it didn't work for me. And then I would go, so then I came over here and went through like these systems like ADACT and Swain, and it was all wonderful. But at that time, MAT had a lot of stigma and it wasn't offered like on the unit. And again, no one's fault. We were just trying to, catch up. And I just kept trying and I support NA and AA. It works for a lot of people, but it was not working for me. It actually did the opposite. I would leave feeling really upset because I didn't have a lot of time or I had to get a white chip, and again, I think that's important about, all pathways work, and it just wasn't my pathway, but I didn't know that. So my first barrier was that no one at that time offered me the option for MAT. So one of the things that I speak on a lot is making that, and we do now, like I know, making it one of the first options. So if I'm an opioid user and I want to try MAT, okay, let's try it. How are we going to do this as far as funding? And so when it does come to funding, that's part of what we do. Sunrise is find grants that help pay for medication, and then help transport people, because obviously transportation is a barrier, especially in rural counties. And so we find funding to bridge those gaps. So once I finally did get on MAT, that changed my whole life. I sometimes wonder, hey, if it was offered to me the first time, would I have my 13-year-old in my life? Because I don't, because it took me so long to get it together. So when I think of my journey, that was one of the barriers. And then kind of following that up is I'm like 5 years in, and I was just talking a minute ago to Dr. Fagan that the pharmacy is still a barrier for me. For years, I've been going to the same pharmacy and they act like they just met me, or and the other thing is, I'll never forget, I was trying to go to a recovery conference and I needed my Suboxone 2 or 3 days early, and they denied me after 4 years. Like, what am I going to do with 3 strips of Suboxone or 6, whatever? I had no issues. So that to me is one of the biggest barriers. Every time it comes time for me to go to the pharmacy, still, I have so much anxiety that I'm going to get there and they not have my medicine. And I'm saying when I'm on a schedule, if I don't have my medicine at a certain time, it's kind of big deal. And they don't treat it like that. They'll come back tomorrow. It's like, no, I might not make it overnight. And I know that's real. And And people say, well, just come off. Well, I'm not coming off. I don't have like an end date. This is what works for me. The other part of that whole thing, and this is again like a barrier, is I figured out after years that only this one brand worked for me, right? And it's the name brand, and I can't, and the others were not working, the generic. And so I cannot imagine someone who did not have didn't feel confident enough to speak up on this. I can't imagine what they would go through. And that's why now when I'm working with people on MAT, I give them my story. Like, this is what I had to do, but I had to beg and pretty much beg a pharmacy to keep the name brand on stock so that I would be well. And it don't cost them any extra money. And I know the pharmacies are busy, but I'm just saying that even today, 5 years later, the barrier is the pharmacy. But yeah, so, to be able to get through that, I truly believe in peer support. Obviously, I believe that clinicians and everybody is important in the process. But for me, if I'd had a peer support come to the jail and say, I've been here, here in the jail, and hey, do you want to try MAT? Holy crap, that would have been it could have changed everything. And I know we're doing some of that now. And just as that, to me, I know peers aren't the solution to everything, but for me, it helps get through those barriers because you have a person saying, I made it through this system and I can get you through this system.
Awesome. Great. To touch kind of on all that, my mind starts racing as I hear the word barrier because there are so many. The few that come to mind specifically that we've sort of tried to address, one is obviously increasing the lived experience availability. So having more people with lived experience, whether it be mental health, substance use, or I say simply homelessness, but it's not obviously simple, but people with lived experience that can be more than just, hey, I'll see you once a month, we'll talk about things. One of the biggest benefits of our program is because of, especially with the MAT side, we have someone from our team coming to meet with someone every single day. So they're getting that medication for the first few days. We've seen, I think, connecting to MAHEC, it's been like a 94% success rate of the people that we've given the medication to. Now, remember, these are homeless people under bridges, under a different bridge every night, and we've been able to stay engaged with them and get them to treatment. And I think that's a big point of that is having that, because for instance, we have some resources here that do great work, but they're stretched thin and they don't have the staff available to have that consistent contact with people or be assertive enough to go find people and track them down, because you can really show somebody you care when you won't take no for an answer on trying to get them some support. So all of that I think is a huge help. Some of the other barriers we've seen are agencies focusing on what insurance requires. And I understand they're, to bill for service, which is important. We're looking at ways to be able to bill for some of the stuff that we do now too. You need that for sustainability and for a lot of other reasons. However, if you think about all the barriers that's creating, oftentimes I see programs requiring people to do groups to get medication, which is great and it does help. But the reality is there's a lot of people out there that need to work for their, not only for their sustainability at home, but that may be a huge coping skill for them, right? And you put them in a group of a bunch of people where they just have social anxiety and that's one of their triggers for use. How therapeutic are you being? Oftentimes I hear probation and parole officers will have somebody on MAT doing pretty well. Their drug screens are clean, but that officer will still say, nope, you got to go to detox. I've had people stable, no use for 2 months and their probation officer would not let them move forward without going to treatment.
Can I say something about
Yeah,
that too?
absolutely.
We can't take people in detox if they don't need detox, right? So there's a lot of this perception that if a person relapses, they need to go to detox, or if a person, in the system makes it such that this is the answer to everything, but it's not the answer to everything. We need to detox people when they need medical detox, and then we need to get them out back into the community and stuff. And so, but we have these folks who are mandating stuff that is not the appropriate treatment for them, right? So that's a barrier.
So a barrier that you're saying is that people actually knowing the system of how it works.
Right.
Yeah.
And
that
not using
mandate
their
piece.
opinions about it too.
When you put Mandate on there, It changes things.
And so all of you all take care of our folks in the community, but what about caretaker fatigue? I hear you all talk about a lot of the other barriers, but what about those barriers of keeping good folks in the program to continue to take care of our community? You can answer. if you
Okay,
want
so
to, Christine.
just so I'm hearing this right, so the folks that we're serving, how do we continue to?
How do you, and the people who are
us.
doing the serving?
Oh, okay, yeah. So as an organization, one of the first things that, and I take no credit, Sue is back there and this is her, kind of, I mean, if this is like what we stand by is self-care. Like if we cannot be well, then we cannot help people. And if we try, it's not gonna be the type of, it's not gonna be helpful. So self-care, we actually implemented, and I'm sharing this as ideas for, other organizations, but we implemented 4 wellness days. So each quarter, say you just have a day that you feel like crap, or you just like, right now our schedules are overwhelmingly busy.
Mhm.
But at the end of the day, nothing is going to fall apart if you miss one day or even 2 days or even a week. Like I know it feels like it at times, but we have implemented the wellness day for those days that you just want to go get a massage or go shopping at the mall. And to me, that means so much. And not only is like, I can speak on self-care all day, because again, that's what we harp on. And again, we're all peer supports. We're all in recovery, all the way from executive director down. So our wellness has to be priority. And so the wellness days, and then just being transparent. I know this month has been really, really hard for a lot of our executive leadership and leadership. It's just busy season. I mean, people are out. I feel like the weather, people are coming in. We got trains. Everybody's excited. We're here together, which is really awesome. But I can let Sue know, like, hey, this is too much. And she'll, guide me and like, okay, we'll take this off. Maybe it's not as important, or just take the day off. And like, to me, that means so much, that because in my brain, like from a corporate side, oh, I got to get all this done to make her happy. Right. And that is so far from the truth. So I don't know. We actually just built or bought a space for our staff. We call it like the wellness center. It's just for staff, and we're gonna have like little exercise bikes. We might do chair massages every now and then. We have like bean bags. The lighting is calm, because the work we do is can be so, I want to say chaotic. That's not the right word, but it's very intense. If you come into our center, if the energy, you will feel the energy. Either people are really activated, and then I go and I'll get activated. And so there's times when I have to physically, like this will be a good example of me going down to our wellness center and like taking a downtime. And that's just like amazing. Yeah.
We also have to pay people what they deserve to do this work, right? So like Sam, Sam is wonderful and wants all the self-care, and we love Sam. I love Sam. And she needs to be paid.
And I am
and
paid.
I know you are.
And that's why I'm
And
here.
I'm not saying you specifically,
I know.
but but we often don't pay caretakers enough, because we act like they do it because they want to, and they do. But you have to pay people enough to do this work, right? Because it's a toll on everybody that's involved, and we have to prioritize systemically paying people to stay in this field too.
Well,
Because people get burned out really easily.
And if I might add, if you haven't figured out by now, I'm very huge in education. Now, if we are able to have people like
Samantha.
Sorry,
It's okay.
if we are able to pay them well, it would be amazing if we are able to train them very well too. So all those fundings are so necessary to be able to help people. So that's it. All I want to say.
One last thing. I know I'm a talker, but that is a perfect example of we do have a program for the people that we're supporting. They get so far in their recovery, we give them an opportunity to be a peer, which just like that, it's like the circle of life, and I think that's part of why peer support works. Is we're like, hey, let's help you get well, and then you can be a peer support. And we've seen examples of people like, there's people that's been in jail that both Justin and I have worked with that are doing the dang work, running programs.
Mhm.
And so I think that's important. It's giving our folks opportunities to learn. So part of the
That's good.
education, we educate and train them.
Well, all right, so I'm going to ask a question about the BIPOC community. And I know that you all can't speak from like personal experience, but as being a person, well, Sergio, you can speak as a person of color. And so, but the rest of you cannot, but how, Samantha, you too.
Okay.
Yeah.
So I'm just what,
Well,
like,
this, this may be easier than I thought it was gonna be. Yeah, but you can talk about your professional interaction. So the trend data indicates that BIPOC communities are increasingly being impacted by substance use and making up a disproportionate amount of lives lost to overdose. But we also see that there are very limited options for BIPOC community members to receive recovery care and resources for cultural reflective providers. Can you speak on the impact of these dynamics of on the road of the recovery journey and overcome? Let me repeat that. Can you speak to the impact of these dynamics on the recovery journey and outcomes for the BIPOC community members? And we have to remember the history of African Americans due to this is not their first drug epidemic. We know that in the 80s, they were flooded with crack cocaine into the community, and their experience was completely different than everyone else's. It was the mothers were jailed, their children were taken, families were destroyed. And at this time, we're seeing a complete different reaction to this epidemic. So we have the history, we have the second time this has happened, and we have the distrust. So how are you all helping those folks that you work with who know this history and have lived this history?
You just mentioned the word, to me, it's very important. Trust. In order to help somebody, they need to trust you. They need to know that you're there with them. And yes, I'm a person of color. And somebody might identify with me just because we're both from Argentina or whatever. So trust is very important, and having the trust, not just for the person that you're working with, but also the family. For example, at Unete, they're here today. Although they help a lot of people, they have a really, I haven't seen trust like Unete has with the Hispanic community. So if somebody tells you, hey, listen, I might don't do A, B, or C, but I know who does it. To having that referral for somebody that is trusted in the community to come to work with you is very important because the trust is there. Now, if we go specifically to the Hispanic community, we're a little special. We like to keep it in-house. We like to solve our problems ourselves. We don't go out there and spread all our problems out and in the open. And for that, the word trust is very important. That word, it is, if it is not the first one, it's probably the second word that should be when somebody's trying to get help in the community. It is something that it's hard to get in, but once you're in and those people trust you, good Lord, it is great. And for those of you, some of you guys are struggling to get into the Hispanic community, I suggest stop doing it yourself. Ally with somebody that has that community with already the trust in the community. And I mentioned Unete because I see Norma, she's right here. She's the executive director. So all I can say about that, it is trust is very important, and especially in recovery.
Yeah, no, totally. I am Native American. I'm from Cherokee. When I came over here, there wasn't like a program to follow up with me that was enrolled members. And I think that's why we created Shakwo, Don and I, and the language is in Cherokee because we specifically wanted to, make sure that we were being culturally inclusive. We hired people that were Native American and or grew up on the reservation and were familiar with the reservation, the resources, even though there's little. That was very important to me and still is. And the whole reason they reached out to us as a non-enrolled program, Sunrise, or Native American original program, like when they reached out to us was because I'm an enrolled member, and they felt, they trusted me which is like major as a reserve, how you say, we don't let people in, like we have our tribal council and we have our tribal programs. And so the fact that they let a peer support, a nonprofit peer support from Buncombe County come in and start a program was huge. And I took that very seriously. We're working on getting our flyers in Cherokee because we want to keep the language. The whole goal is, and we serve most of actually, I think 99% of the people we serve are Native American. We do keep it open because we know non-Native Americans come to Cherokee and get stuck because they are, either mothers or friends, and so we do serve non-enrolled, but yeah, so I don't know now, like what happens is if a Native American comes, say through ADACT or any of the programs really in Asheville that know about us, if they say they're enrolled in Cherokee, they'll usually give us a call. And I think that's really cool because we can make that connection. And then if someone's curious, if they're part of Cherokee, there are a lot of questions around their like background and history, we're able to connect them to the right people, which anyways, it'd be cool if I got out of ADACT or wherever and they're like, you know what, we have this group enrolled members that work in recovery. We're gonna have them come talk to you and see what your options are. And our funding is for those folks. So anyway, that was kind of the whole thing, the whole reason I created She Quo Donna. They are living again. So
I think too, we're really lucky in Buncombe County to have a lot of these organizations. And so we should let them lead. We should really listen to them. I'll name a couple like Umoja, BIPA, Sisters Caring for Sisters. My daddy taught me that, Operation Gateway. All of these are organizations that we should be asking them to take the lead on these issues and then letting us follow their lead, I think.
yes.
Justin, you want to add in something?
Yeah, so.
Look in your eyes.
Well, I want to be careful, and I really wish that we work very close, we contract with Umoja. For those of you that don't know, they're a local agency that provides peer support, mainly specifically to the Black, Indigenous, people of color population, although they'll, work with anybody that comes in. We partner with them for a lot of different reasons, one of those being to give us, hopefully, and we're very close to moving more into that soon, but giving us that connection to some of those communities that have been difficult to reach, especially through the system. We are a government entity. We try to dress down as much as we can, but I still have this emblem on my chest. And as I walk into places, oftentimes because of their past experiences that completely correlates to trauma, whether it be within the system already or just through, racism they've experienced through their life. There's a lot of aspects there. We sort of took that approach with the homeless population, treated that population as a disenfranchised population. We first started working with them. One of the things I'm proudest of with our team that I can say now is oftentimes this population will now refuse support from other people that may come to a 911 scene, but they'll say, if you call a community paramedic, I'll talk with them. Sometimes it's people we've never even met before, but they've heard about our approach with people through their friends on the street. And so that's kind of our hope with some of these other communities, just to go in there proactively to help show them why we're there. And we want to offer support and be real with them to try and break down some of those barriers. So I think that's important to mention too. Another thing I'll say, the numbers, a lot of people are talking about the numbers increasing disproportionately with the BIPOC population. We are not seeing that with our overdose data, but that data is coming from people that are calling 911. Mm-hmm. And what I'm learning as I'm working more with these individuals is that these are not populations that are going to call 911, because as soon as they do, law enforcement's coming. Now the heat's on the area. Now their cousin that maybe they've been looking for a while because there's a warrant. Now they got to worry about if he's going to, so there's tons of reasons that I have very little understanding of on why these places are not reaching out for support. So the overdoses are happening, but they're not calling. And so how do we bridge that gap, helping people understand there are safe resources out there for you? So it's a big question and one I don't have an answer to yet. Maybe we can all get there together. What's that? Partnerships. There you go.
Well, due to time, I have to close the panel and open it to the floor. We are now at 1:36 and we're going to open discussion with the public until 1:50. So at this moment, I would like to allow everybody in the room to take a deep breath and acknowledge that we have a lot of work to do. That's the last self-care breath you will take today. So, all right, so if you're comfortable and you would like to ask a question, please raise your hand, and Victoria, if you could also help out on that end of the room, I would super great that, and Catherine. And I'll try to manage this side, okay? So, do we have any questions for this amazing panel? Well, if you don't have any questions, I'm going to ask the panel one more thing. Okay. So this is for each one of you all. If there is one thing you could share with this group, just one thing, personal, public, whatever, and then that you want them to leave with a day, what message would you leave? What message would you want to leave this discussion with? And we'll start with you, Aaron.
Thank you. Thank you. I would say that people recover if we allow them to do it in the way that they need to and want to, as opposed to the way that we want them to. And so taking our judgment out is the most important thing, I think, that we can do for people.
I love that.
All right, Justin.
Such a tough question. I'll touch on that and say, yeah, absolutely, recovery is possible for those of you that have met people in your work or just life. There's plenty of, not only am I sitting in front of you as someone that didn't think I'd ever make it, didn't want to make it at one point in my life. And I've also worked with a lot of people that honestly in my head, I've wrote off too, as I've been working with, still showed up, but I was kind of like, this isn't. And those are the people that are doing really well right now. So I think that's important, is to try your best not to write people off as hard as it can be, but that goes back to the judgment piece. The other thing that I'll say is I think a big answer to all the problems we're seeing is collaboration, right? One of the first things that I did when we started our program was start finding the agencies that were open to easy collaboration and try to work with those closely. And we've built a pretty cool network where I can pick up the phone and call somebody and have a call back that same day with a resource if I need it. Same for here. People know they can call us for the same thing. If I have items that I can share with other agencies, I will. So I think that's another thing to think about is if you guys are in positions working with other agencies, how can we increase that level of collaboration so it's smooth? So, thanks.
Yeah, I guess my turn. Mine comes with a little bit of a story in history. You all heard it takes a village. In 1953, University of Hawaii conducted a study. They took 2 families of rat and they let them live together. At one point, they took 1 rat from each box and put them, I'm sorry, I forgot an important part in there. With that rats in the boxes, they have water with opioids and water, just regular water. Rats would come and try to drink the water with opioids, get repulsed by it, go back and drink the regular water. They did that constantly for months. And both boxes were the same. They took 1 rat for each box and they put it, and they had the same options: water with the opioids and water with regular water. After a while, both rats started drinking the water with the opioids. Then they took one of the rats, put him back with the family, and that rat kept going back to drink the water with the opioids, eventually stopped, started drinking regular water, while the rat that wasn't put back with the family drank enough water to die and overdose. It does take a village. One of the main triggers for a lot of people is loneliness, one of the ugliest feelings that anyone can feel. Being part of a community helps a lot. Be care for the community, people, places, and things. Those are triggers, right? But if you have the right community and you have the right attitude to be able to get into recovery, you're gonna get far. The way I like to divide this is in 4 pieces. The first part of the community is one's itself. You want to want the recovery. Second one is the family. The third one is the people that you have around. your closer community, like your neighborhood. And the fourth one is very important. That's us in this room. Without us, if somebody needs the help, they might just don't get it because we put too many barriers. So if I want to leave this place or these wonderful people here with a thought is, if we're here to help, instead of us, or instead of the people that's looking to help cater to us, we should cater to them. So if there is one thing I would like to do is that, and the second is get the school involved. A lot of parents don't want to hear, why are you teaching my kids about this stuff? Well, your kids gonna learn it whether you like it or not. You're gonna learn it in the school, you're gonna learn it, or not in the school, on the street, or you're gonna learn it from your parents. I rather, if you ask me, to learn it from me. If my kid asks me, I will tell him anything he wants to know. If we can have that collaboration with the schools and they can have more knowledge when they come to the street and they come to the moment to make the decision, should I take this or not, the more tools that they have in their pockets, the better.
I'd say just, treat people like humans. The people we're serving are it's us. And so, be kind, use non-stigmatizing language, maybe they don't want to be called an addict. Maybe they just want to be called by their name, or, honestly, just humanizing folks, because it's, I don't know anyone who's not been affected by some kind of struggle, substance use or mental health, but yeah. And on the flip side, as far as systems, and I know a lot of people here from the county, but trust your peer sports, let them in the system. Obviously there's precautions and, but it does work, and give us a space at the table, because I think it can make a big, it can help when people with lived experience are sitting at these tables talking about how to help people with the same struggle that, we as lived experience have. So let us be at the table and treat people like humans.
Okay, so before I close, I want to share a couple things with you. So hold on, this is important. If you have parking, we have parking validations to get you out of there. We have the QR code button, and we have buttons and magnets that are on the table outside, and information for the public input site. And as you leave today, I always leave any audience that I work with and moderate with, I always leave with some seeds to sow. As you gather to leave today, you will interact with people who have experienced many things. And today we talked about folks who are dealing with substance abuse issues. And if you are interacting with someone who has a substance use issue, look beyond the substance use. Look beyond the substance. And you will see someone who once was a child who sang, row, row, row your boat, bob, bob, black sheep, jump rope, played with trucks. If you look past the substance, you will see a kid who read his first chapter book and was excited and knew their favorite color and knew their friend's favorite color. If you look past the substance, you'll see a teenager who was full of life that couldn't wait to grow up or wait to go to college or just wait for Friday. If you look past the substance, you will see an adult who had dreams, and their dreams were deferred by trauma. If you look past the substance, you'll see a heart of someone who still wants to have that dream. And even in the midst of their cycle of substance abuse, they're still dreaming. So instead of being the barrier to help them get to that dream, be the gatekeeper that helps them light their path and walk towards their dream. With all of you, take care of each other and take care of our community. Thank you so much.
That was so good. Sue's back there bawling.
Thank you so much to our panelists and Zakia. Thank you all for joining. We appreciate it. A reminder about our website with substance use resources. We have a place, if something's not there, it's been a work in progress adding. Please add your name, information. We'll be continue to expand that. And then our other QR code, we'd love to get your feedback. What are some intentional strategies that we can do to outreach our BIPOC community? That'll all be on our public input page, which this will take you there. And take a bunch of these and
QR.
share the QR codes,
Yeah.
the magnets, buttons, wear your buttons, hand them out to some others that weren't able to be here. And again, thank you all. Have a good one.
Thanks. You have a good night.